Good evening, everyone. Today's topic is on ophthalmology for Mrcp Part 1, I guess. We have selected few topics which is relevant to the question, maybe around 15. And most of the questions come from these articles only. So let's go through it. First of all, what are the visual emergencies due to vascular cause? Mostly the questions comes from either central retinal artery occlusion or central retinal venous occlusion. So, 84-year-old gentleman complains of loss of vision in one eye since morning. So, sudden onset. He's otherwise asymptomatic. No associated eye pain, especially on movements. So, no associated, I'll say, the inflammation going on. Past medical history includes ischemic heart disease. So, patient is a vasculopath, and they say that on examination, there is no vision, complete loss of vision in the left eye. So it is not a partial vision or one part of the field is not visible, it's a complete loss. And they'll give like this the fundoscopy finding, which shows a red spot with a pale retina. So, what could be the most likely diagnosis based on these symptoms and signs? Is central retinal artery occlusion. Why? Because it's a complete loss of vision, sudden onset, like a vasculopathy, and the retina is pale. You can see in the fundoscope picture the narrowed vessels, a macular infarction probably causing the cherry red spot, and decreased blood supply causing the retina to be pale. So these features suggest painless sudden loss of vision in a vasculopath with the very pertinent fundoscopic features, central retinal artery occlusion. So like any vasculopath, patient will features like hypertension, diabetes. The most important, the fundoscopy finding and sudden loss of vision, painless, and with the fundoscopy. Okay. So early identification is very much necessary because one part of the eye is completely loss of vision. How to treat that depends on the cause. If it is diabetic, hypertensive, stroke kind of feature, then has to be optimized. Otherwise, if it is a vasculitis related to inflammatory disease, then of course the inflammation modulators like steroids and other medication has to be given. Okay. The other vascular emergency is central retinal venous occlusion. So here again the similar kind of feature: 74-year-old elderly gentleman, sudden painless loss of vision, who denies any
Excuse me,
photo.
sir. So sorry to interrupt. Actually, sir, the slides are not moving. It's
Okay.
the slide is freezed in slide two. Yes, sir. Now it's fine.
Okay, maybe slow. Now you can see central retinal
Yes, sir.
venous occlusion. Here also sudden, painless loss of vision may be painful, and there will be floaters and flashes, but not there. So sudden, painless loss of vision. Typical fundoscopic findings are retinal hemorrhages, or typical fundoscopy features are like a stormy sunset sign, what they call, because of the multiple hemorrhages. And if you do fundoscopy, the hemorrhages will be all across the scope. So if it is a part of the scope, then it will be probably branch retinal artery, retinal vein occlusion. But it is throughout the fundoscope finding, then it's a central retinal vein occlusion. Here it will be stormy sunset sign. Okay, the diagnostic hallmark. So it will not be pale retina. It is stormy sunset sign, retinal hemorrhages, and of course there will be swelling and cotton wool spots and tortuous veins. So stormy sunset sign, venous occlusion, sudden painless loss of vision, pale retina with very narrowed vessels, arterial occlusion. Both are painless, sudden loss of vision. In branch retinal vein occlusion, the part of the field will be filled with retinal hemorrhages. Otherwise, in central retinal vein, it is completely the same picture. How to treat? The vasculopath has to be treated with anti-VEGF factors or laser photocoagulation so that you can save some part of the vision. Okay. Of course, it may resolve over a few months, but ultimately you do a ocular CT scan, I'll say, to see what more can be done. So both central retinal artery and venous occlusion are emergency situation. If the patient is coming to your clinic, has to be referred to a ophthalmologist and should be differentiated by the fundoscopic finding. Now coming to the other causes of gradual loss of vision, this is retinitis pigmentosa. So patient will complain of gradually losing the peripheral vision. So key
Mm-hmm.
features of this is gradual progressive vision loss. Two main features: night blindness and progressive tunnel vision, which means the peripheral part of the vision is lost. It's not a sudden vision loss, it's a progressive one. And in any question, the two things must be there: gradually onset tube vision and night blindness. So what is happening in the fundoscopy? Black spicule shaped deposits they will report in the peripheral retina, and the retinal vessels will be gradually attenuating. And if you see the optic disc, they will specifically mention there is a waxy pallor. So it's vascular layer of the main optic disc is gradually slowing down. It may be associated with some congenital symptoms and with that features, but these are not that important. Main issue, the two features you have to remember for the examination purpose: night vision loss and gradually onset peripheral vision loss causing tubular vision. The other causes of vision loss may be like this: 71-year-old gentleman with diabetes and hypertension complaining of light flashes in the right eye. These symptoms have been present for last 2 days only, and more in the peripheral part of the vision. So it's not the whole retina. Some part of the retina is getting affected. So of course the visual acuity will be affected, and the causes may be many because it is a painless loss of vision. So it may be vasculopathy, but vasculopathy usually occurs suddenly. So something else is going on. So you have to see what is happening. Usually in a normal line, the reflections goes to the back of the retina, but here it is falls short. So the distal vision will be affected much more. Like it will happen like a high myopic patients. So probably the vitreous is getting detached. It occurs with advanced age and more in low light. So the floaters, the patient will complain of floaters, which will be like something floating in the vision, or maybe some flashes, like some bright lights will be flashing in the eye. So overall, the visual acuity, especially at night, will be affected, and may complain of, especially in the question, some curtain descending in the vision. So suddenly, some of the vision is obscured by the curtain. So this shows that there is vitreal detachment. Okay. If it is much more bigger, they will complain of this rings, which is called Weiss ring, a big ring color area in the because of the vitreous detachment. Or in the slit lamp examination, it can be found that the vitreous layer is getting detached from the retinal surface. And if you do a optical CT, that is OCT, that will confirm your diagnosis. So next step of diagnosis in a gradually progressive loss of vision with flashes and floaters. Ultimately, you have to confirm with OCT that the vitreous layers are getting detached. So there are few differentials. One is vitreous detachment, which is showing these flashes and floaters. Retinal detachment, which is progressing to the central vision, and vitreous hemorrhage, which is usually occurs very suddenly, so it is sudden loss of vision. But other two are mostly more progressive and slow loss of vision. Ultimately, differentiation must be done with the OCT, which will show a vitreous detachment. So both are mostly emergencies. So you have to refer the patient to ophthalmologist for a laser treatment, and patient has to be educated about gradual loss of vision and taking of the other vasculopathies, and if there is some amount of inflammation that has to be checked. Now coming to the other most common causes of worsening of vision is open angle glaucoma and narrow angle glaucoma, acute one. So here, basically, uh, in the primary open angle glaucoma, what happens is basically resistance to the flow of the aqueous. So there is no narrowing of the angle, but it is increased resistance of the aqueous humor drainage, and it ultimately causes irreversible blindness. So usually the questions comes like with the clinical features and how will be the treatment of it. The pathophysiology is basically, as I said, the trabecular meshwork of the aqueous humor is functionally obstructed. So ultimately, the aqueous humor will accumulate, and that will increase the intraocular pressure more than 24 as per the NICE guideline. More commonly happens in elderly age group or who are myopic and other vasculopathies like diabetic and hypertensive. So a patient who is diabetic, hypertensive, myopic, going to a cinema hall and suddenly having increased pain in the eye, which is gradually progressive for a few days in dark light.